Hypertension is the major risk factor for a wide range of cardiovascular and related diseases, and it is often combined with other conditions leading to a marked increase in cardiovascular risk. Blood pressure levels must be normalized in all hypertensives, but particularly in those with higher total cardiovascular risk. When concomitantly present, raised blood pressure levels and other risk factors potentiate each other. This leads to a total cardiovascular risk that is higher than the sum of its individual components. Prompter initiation of treatment is advisable if grade 1 hypertension is associated with a high level of risk, or if hypertension is of grade 2 or 3. Beta blockers, thiazide diuretics, calcium antagonists, ACE inhibitors and angiotensin receptor antagonists are suitable for initiating and maintaining antihypertensive treatment, either as monotherapy or in some combinations with each other. Nebivolol, with its dual mechanism of action, first, most cardioselective beta-1 blockade, and second, NO-mediated vasodilation, shows an optimal safety profile and blood pressure lowering effects among antihypertensive drugs. One of the most important features of nebivolol is the favorable hemodynamic effects. In this graph, we can see that compared to atenolol, nebivolol significantly improves left ventricular ejection fraction and stroke volume, preserves cardiac output, and decreases peripheral vascular resistance. At doses producing the same blood pressure reduction, nebivolol lowers heart rate significantly less than atenolol, and because of the lesser bradycardia combined with peripheral vasodilation, it has better effects on aortic blood pressure than atenolol does. It has been shown in this study that both compounds produced an equal reduction in brachial blood pressure, but aortic pulse pressure was reduced to a greater extent by nebivolol. Conversely to other beta blockers, nebivolol affects neither glucose nor lipid metabolism in patients with hypertension, diabetes, and/or heart failure. An outstanding result coming from the seniors trials show a trend of fewer new cases of diabetes during treatment with nebivolol. Thanks to its safe metabolic profile, nebivolol has a particular mention for antihypertensive therapy in the ESH 2009 reappraisal of European guidelines on hypertension management. The optimal tolerability profile of nebivolol positively reflects on important aspects of patients' quality of life. Erectile dysfunction is one of them, and again, as opposed to other beta blockers, nebivolol shows that it does not affect sexual activity. Here, we can see that about 30% of patients switching from other beta blockers to nebivolol improved their erectile function. A wide number of clinical trials have demonstrated the efficacy and tolerability of nebivolol in hypertensive patients. As is shown in this graph, nebivolol 5 mg once a day is able to respect the circadian rhythm and reduces blood pressure for the whole 24 hours. Compared to other beta blockers, Nebivolol showed significant better rates of treatment response when compared with both atenolol and metoprolol. Similarly, compared to ACE inhibitors, Nebivolol demonstrated a higher rate of response than lisinopril and enalapril. The last comparison is between Nebivolol and ARBs. The percentage of patients responding to treatment was significantly higher with Nebivolol than with losartan after 6 weeks of treatment. Nebivolol produced a significant greater reduction of diastolic blood pressure. In conclusion, Nebivolol 5 mg per day demonstrates to effectively lower blood pressure over the 24 hours with peculiar favorable effects on cardiac and systemic hemodynamics. Blood pressure reduction by Nebivolol associated with its optimal metabolic profile provides hypertensive patients a high quality of life.